Good day, everyone. I will be discussing the different laboratory tests used to evaluate liver function. So, before we proceed with these tests, let's run through first the common facts about the liver. So, liver is actually a dual organ having both secretory and excretory function. Secretory in a sense that it secretes substances that may be used for metabolism. Excretory in a sense that your liver also is an organ capable of excreting out metabolic waste products. And the liver is considered the largest gland in the body, weighing about 1.5 kilograms in man. And this is usually located in the upper and right side of the abdominal cavity immediately beneath the diaphragm. So the liver, being located beneath the diaphragm, is basically situated on top of the stomach on that side of the right kidney and the intestines. And it is usually shaped like a cone and dark reddish brown in color that weighs about 1.5 kilograms. So there are actually two distinct sources that supply blood to the liver. So I want to direct your attention to these vessels here, okay, going into the liver. So these blood vessels are actually the sources of the blood supply of the liver. So oxygenated blood flows in from the hepatic artery, okay, and then nutrient-rich blood flows in from the hepatic portal vein. So the liver holds about 13% of the body's blood supply at any given moment, and it is consists of two main lobes. Okay? So two main lobes. Now, both are comprised of 8 segments that consist of 1,000 lobules or small lobes. So you have two main lobes, and these lobes are actually comprised of smaller lobes or lobules, no? About 1,000. And these lobules are connected to small ducts or tubes that connect with larger ducts to form the common hepatic duct. Okay? So the small lobes, okay, they actually connect together to eventually merge and form the common hepatic duct. And the common hepatic duct transports the bile made by the liver cells to the gallbladder and then eventually to the duodenum via the common bile duct. Okay, so I will be discussing more of these in the succeeding slides of my lecture. So this is other views of the liver showing you a more clear view of the different lobes. And as I've mentioned, the lobes are actually comprised of 8 segments. No? So we have first segment here, second, third, fourth, fifth, sixth, seventh, and eighth segments. Each segment supplied by a particular extension of the hepatic vessels. So the liver actually has many functions. Okay? And a one important function of the liver is that it is capable of synthesis. And what are these substances synthesized by the liver? So this includes plasma proteins, carbohydrates, lipid lipoproteins, clotting factors, no, particularly vitamin K dependent factors, ketone bodies, and several enzymes. Okay, so the liver actually is capable of synthesizing so many substances, and these substances are actually used by the body, okay, used by the cells as nutritional support or for metabolic purposes. So normally it produces 12 grams of albumin daily. So you learned already that albumin is actually a type of protein. Okay, so we will discuss more on this in the next few slides. And this is also involved in the metabolism of cholesterol into bile salts. Now, another function of your liver is that it is capable of conjugation. What does that mean? So, conjugation would actually mean metabolism of your bilirubin. So, normally, bilirubin is produced from hemoglobin metabolism. So eventually, when you break down hemoglobin, okay, particularly the heme component of your hemoglobin, it will actually be metabolized into the different fractions of bilirubin. And once this bilirubin, goes into the liver, okay, so it is there conjugated, thus the conjugation function of the liver. So I will be discussing more of these, in the next few slides. So about 200 to 300 milligrams of bilirubin is produced daily in the healthy adult. Now, another function of the liver, which I think you're very familiar with, is the detoxification. No, it's detoxification function. So it serves to protect the body from potentially injurious substances absorbed in the intestinal tract and toxic byproducts of metabolism. So for example, so you are alcoholic drinker. So normally, your alcohol metabolic products of alcohol are actually toxic to the body. And so your liver serves to detoxify it by neutralizing or by binding to these toxic waste products, no? By producing different enzymes capable of destroying or metabolizing or inhibiting production of these metabolic toxic products. Now, um, another way of determining its detoxification function is via conversion of your ammonia into urea. Okay, conversion of ammonia into urea. So I will be discussing that later also. Another function of your liver is excretory and secretory, both excretory and secretory. So by excretory, it would mean excretion of bile acids or salts, bile pigments, or bile cholesterol. So remember I've mentioned that your hepatocytes are capable of actually producing bile. And these bile flows into the sinusoids, eventually the lobules, and when the lobules merges, no, it basically forms the common hepatic duct. And from there, the the bile is actually excreted into the duodenum. Okay, so these bile acids or different forms of bile are actually used for digestion, no? Digestion, and common bile acids excreted by the liver are in these forms: cholic acid and ketodeoxycholic acid. Bile acids are conjugated with amino acids, glycine and taurine, forming bile acids. Now, another function of your liver is that it is capable of storing fat-soluble vitamins and water-soluble vitamins. And your liver also serves as a storage depot for glycogen, which are released when glucose is depleted. If your body is actually short in glucose, the liver actually, by the process of glycogenolysis, would actually cause breakdown of your glycogen to produce glucose, no, to supply glucose to your cells. Okay. Now, I will be discussing the different laboratory tests or parameters used to measure these different functions of the liver. So let's start with hepatic, no, synthetic activity. What are these tests used again to measure liver synthesis function, synthetic function? So again, remember I've mentioned that the liver is capable of producing or synthesizing so many substances, no macromolecules or even smaller metabolites. These macromolecules include, again, protein, carbohydrates, lipids, cholesterols, and different enzymes. Now, measuring these substances is actually useful for quantitating the severity of hepatic dysfunction. Why? Because when there is hepatic dysfunction, your liver now will not be capable of synthesizing these normal components synthesized by the liver. So normally if we determine its level in the serum, when there is severe hepatic dysfunction, there would be decreased amounts, no, of these substances, particularly for example your total protein, which are actually mainly synthesized in the liver. Now, the different parameters that we use in the lab to measure hepatic synthetic function may be, no, protein, particularly serum albumin, and determination of the different vitamin K dependent coagulation factors. Why? So again, remember your liver is capable of synthesizing proteins and different coagulation factors, particularly vitamin K dependent coagulation factors. These coagulation factors are actually capable of hemostasis. No, its main function is to actually stop bleeding. No, when there is injury or when there is an insult into your endothelial cells, eventually leading to activation of platelets and then activation of your coagulation factors. That is to actually promote stoppage of bleeding or hemostasis. Now, what I want to point out is that these coagulation factors synthesized in the liver when there is hepatic dysfunction. What's likely to happen is that your liver now will not be able to produce or synthesize these coagulation factors. And these coagulation factors are actually determined in the laboratory, no? Particularly in the hematology department. So your laboratory tests used to assess these coagulation factors would include your PT and APTT. So I will be discussing that later. And to note, these coagulation factors are vitamin K dependent. In other words, your liver will synthesize these coagulation factors using vitamin K as your um, cofactor. Okay, so that's why it's called vitamin K dependent coagulation factors. So these factors includes factor factors 2, 7, 9, and 10. Okay, factors 2, 7, 9, and 10. So these provides the most useful indices for assessing severity of liver disease, such that in hepatic dysfunction or severe liver disease, there would be decreased synthesis of total protein, particularly the serum albumin component, and these vitamin K dependent coagulation factors. Now let's discuss first total protein. Okay, so you learned in the previous discussions that protein, no, majority or mostly all of these proteins are actually synthesized in the liver. So I've discussed also the importance of protein, no, in the body. So your protein actually may be used, no, total protein determination may be used for assessing nutritional status and the presence of severe disease involving the liver, such that total protein and albumin are about 10% higher in ambulatory individuals, and plasma levels of total protein is zero point 0.2 to zero point 0.4 grams per DL higher than serum due to fibrinogen. In measuring total proteins, usually fasting is not required, no? Unlike lipids and carbohydrate determination. And measuring total protein is usually done in the serum. The serum, why in serum? Because serum actually has no fibrinogen and no anticoagulant that may slightly dilute proteins in the plasma, giving us false low results. And take note, during specimen collection, one must be careful not to cause hemolysis of your samples. Why? What happens when there is hemolysis? Remember, your red blood cells actually has proteins inside its cytoplasm. So when there is lysis, no? Lysis of red blood cells or hemolysis, it would actually cause release of these proteins inside the red blood cells, and so it may add up the proteins found in the serum. Another reason why hemolysis would actually cause false elevation of total protein is that usually in the laboratory, we determine the um, the level or the amount of protein via colorimetric method. And so your hemolysis would actually interfere, no, would actually cause increased coloration and so or turbidity. That's why it may actually cause false higher readings, no, giving us a falsely elevated total protein levels. So normally the values of total protein in the serum ranges from 6.5 to 8.3 grams per DL. And the usual methods used to determine total protein are as follows. So we have the Keldal method, which is the standard reference method. Okay. However, this is not commonly performed. So you learned, no, that your Keldal method is actually based on the measurement of the nitrogen content of your protein. So remember, your protein actually contains four molecules of carbon, hydrogen, oxygen, and nitrogen. So your Keldal method would actually measure the nitrogen component of the protein. So it uses a serum treated with tungstic acid, forming a protein-free filtrate. And in determining the amount of protein, since in Keldal method we only determine the amount of nitrogen in the protein molecule, so we actually use a conversion factor such that 1 gram of nitrogen is equivalent to 6.54 grams of protein. Okay, so normally there is 15.1% to 16.8% of nitrogen content. Now, another method of determining total protein is by Biret method. Okay, so Biret method is the most widely used method. So Keldal is the standard reference method. However, it is not commonly performed. Biret method is the most widely used method for total protein determination. So just a review on the principle of Biret method. So in Biret method, cupric ions complexes with groups involved in the peptide bond forming a violet colored chelate, which is proportional to the number of peptide bonds present and reflects the total protein level at 545 nanometers. So again, in Keldal, we determine the nitrogen component of the protein. However, in Biret method, we determine the amount of peptide bonds, no, present in the protein. So remember, your protein are actually comprised of amino acids, and these amino acids are comprised of um, when proteins are actually broken down, it may become forms peptides, and these peptides, when further broken down, produces amino acids. The peptides in turn are actually interconnected to each other by a bond, no, we call it peptide bond. So in Biuret method, we add an alkaline copper sulfate, no, a copper solution which will actually bind to the peptide bonds. Now, this binding is actually proportional to the amount of protein in the circulation. Okay, so another method of testing or determining total protein is via the Folin-Shukaltu or Lorry method. So of these methods that I have mentioned, it has actually the highest analytical sensitivity. So it uses phosphotungstic molybdic acid or phenol reagent and Biuret reagent. Okay, so when you add up these reagents, the phosphotungstic molybdic acid or phenol reagent and Biuret reagent, a positive result would be a deep blue color. Okay, so in Lorry method, we actually cause oxidation of phenolic compounds such as tyrosine, tryptophan, and histidine to give a deep blue color. Now, another method of determining protein is via UV absorption. Okay, so remember you have learned, no, in the previous lectures that protein basically absorbs light. Okay, so it absorbs light at what wavelength? At 280 nanometers and at 210 nanometers. Absorption at 280 nanometers is due to tryptophan, tyrosine, and phenylalanine. So these are actually the amino acid which absorbs UV at 280 nanometer wavelength, tryptophan, tyrosine, and phenylalanine. Whereas absorbance of protein at 210 nanometers is due to the absorbance of peptide bonds at that wavelength. Okay? So for examination purposes, I want you to remember the different amino acids that absorbs UV at 280 nanometers. Now, a method, okay, which is dependent on the migration of charged particles in an electric field is this what we call serum protein electrophoresis or SPE, serum protein electrophoresis. This is actually the single most significant clinical application of serum protein determination, no, is to actually identify monoclonal spikes of immunoglobulins and differentiating them from different polyclonal hypergamma-globulininemia. So um, let me discuss it further, explain this further by showing you the normal, no, serum electrophoresis pattern. So normally, your serum electrophoresis would actually produce these tracings, okay, this pattern. So your albumin will actually is considered actually, you know, or is occupying the first band. Okay, so it's the first band, um, meaning it's the fastest bond, no, since it occupies the first band, your albumin. And take note of the different protein components, different types. Your albumin is actually the most abundant. Okay, now the second fastest to migrate is the alpha 1 globulin. No? So alpha 1, alpha 2, beta, and gamma are actually globulin, no? Globulin components of your protein. And the fastest to migrate of these globulin components is the alpha 1, okay? Second fastest. So usually your alpha 1 increases as a non-specific response to inflammation. Now, the third fastest band is your alpha 2. Okay? Your alpha 2 globulin. And in this globulin, no, remember you learned in your protein lecture that we have actually different subsets of your alpha-2 globulin. So maybe haptoglobin, okay, maybe ceruloplasmin, and among others. Now, the fourth band is comprised of the beta globulin component. So, your beta globulin proteins would include transferrin, beta lipoprotein, hemopexin, and some complement proteins such as your C3 and C4. Now, the slowest to migrate because these are actually heavy proteins, no? Your gamma globulin, occupying the fifth band. Okay, so this is another normal looking serum protein electrophoresis pattern showing us the different proteins under each band. No? So we have different proteins for alpha 1, alpha 2, beta, and gamma globulin units. So these are the normal values for each fraction. Take note, the highest amount or the most abundant fraction is the albumin fraction, comprising about 53 to 65% of the total protein component. Okay, so there are actually instances in which your gamma, okay, your gamma your gamma component is actually increased, no, during serum electrophoresis. So we call this spike, gamma spike. So this is usually present in disease conditions such as in multiple myeloma. Okay? Multiple myeloma. Another um, abnormal serum protein electrophoresis pattern is as shown here in this figure, no, pointed by the arrow, is a bridging of the beta and the gamma component. So normally you don't actually see bridging. Okay, so we call this beta gamma bridging. This is usually seen in conditions or in patients with hepatic cirrhosis. So beta gamma bridging. Now another abnormal, okay, abnormal serum protein electrophoresis is presence, okay, presence of alpha 2, alpha 1, and beta globulin band spikes. Okay, so this is usually seen in acute inflammation. And another one is shown here is a decrease, no, in alpha 1 component. So usually seen in alpha 1 antitrypsin deficiency. Now, alpha 2, okay, alpha 2 globulin band spike is usually seen in nephrotic syndrome. Okay, again, beta gamma bridging in liver cirrhosis and gamma spike in multiple myeloma. So another test used to measure hepatic synthetic activity is via determination of prothrombin time, also known as the vitamin K response test. Okay, so you will learn more of these in hematology classes. However, um, for the sake of discussion, I will be discussing what are the different clotting factors and what's the use of these tests. How come this is used to assess hepatic synthetic activity of the liver? Okay, so prothrombin time is actually used to measure the different vitamin K dependent coagulation factors. So I've mentioned already that these factors are coagulation factors are actually synthesized in the liver. Okay, and once synthesized in the liver, during synthesis it actually needs a cofactor, your vitamin K. Now, in the absence of your vitamin K, usually these vitamin K coagulation dependent factors are actually not synthesized. So how do we do this? Usually, vitamin K is administered intramuscularly 10 milligrams daily for 1 to 3 days. And we determine prothrombin time if um, if it actually gives us a prolonged result, okay? Prolonged result, that would actually mean that we have deficiency of your different vitamin K dependent coagulation factors. So this differentiates intrahepatic disorder from extrahepatic obstructive liver disease. Okay. How? In intrahepatic disorders, you actually get to have prolonged pro time, prolonged pro time or prothrombin time. Whereas in your extrahepatic obstructive liver disease, you get to have normal pro time. Why? Remember, in your intrahepatic disorders, the defect actually is in the hepatocytes or in the liver itself, such that the liver now, the cells in the liver are actually not capable of producing your coagulation factors. That's why if there is incapability or decreased synthesis of these coagulation factors by the liver, as seen in intrahepatic disorders, it would actually give us a prolonged, no, or abnormal prothrombin time results. In extrahepatic obstructive liver disease, okay, what's likely to happen is that there's actually nothing wrong with the liver itself. However, there is obstruction, okay, extrahepatic obstructive liver disease. There is actually obstruction in the passageway of these substances, in the pathways of these substances, no? The biliary duct system, there is obstruction, such that since there is no innate or defect in your hepatocytes or injury in your hepatocytes, it is capable now of producing these coagulation factors. That's why there is normal prothrombin time in extrahepatic obstructive liver disease. Okay? In acute viral or toxic hepatitis, there a prolongation of the pro time or prothrombin time signifies massive cellular damage. Now, another test used to measure hepatic synthetic activity is, again, I've mentioned determination of your albumin, which is considered the most abundant protein fraction, protein component. So its concentration is inversely proportional to the severity of the liver disease. Why inversely proportional? Because the more severe the liver disease is, the less likely it is capable of producing your albumin, and so giving us a decreased levels in a severe liver disease. Okay? Now, plasma levels decline when severe hepatocellular disease lasts more than 3 weeks. And in hepatic circulatory disorder, albumin is used because its concentration reflects the shift of protein and fluid into ascites and its important contribution to plasma oncotic pressure. So the dyes used for measurement of your albumin are the following. So we have bromcresol green, methyl orange, hydroxyazobenzene, benzoic acid, and bromcresol purple. Okay, so bromcresol purple is actually the most specific dye for albumin. Now, albumin is increased in these disease states, no? In severe dehydration. Okay. However, it may be increased also during sample collection when there is prolonged tourniquet application. No, this is termed as artifactual hyperalbuminemia. Now, it may be decreased in states wherein there is reduced synthesis, as seen in chronic liver disease, malabsorption syndrome, malnutrition, and muscle wasting disease. And It may be decreased also in states wherein there is a loss, no, or increased loss of albumin in diseases such as nephrotic syndrome. Okay, nephrotic syndrome wherein you lose 20 to 30 grams of proteins per day. Another disease states where there is increased loss of protein is in massive burns, in protein losing enteropathy, and in orthostatic albuminuria. Okay. Another condition associated with decreased albumin level is when there is increased breakdown of albumin or proteins. So we term it as increased catabolism in conditions such as in massive burns, in malignancy, or in thyrotoxicosis. So another test used to assess hepatic synthetic activity is via determination of your albumin globulin ratio. So globulin is increased disproportionately to albumin in chronic inflammation, in multiple myeloma, and in macroglobulinemia. So if globulin is greater than albumin, it is known as inverted albumin globulin ratio, and the serum and even urine protein electrophoresis may actually help define the clinical situation. So your reference value would be 1.3 to 3:1. Okay? So another um, evaluation of the protein is of the liver is via its conjugation and excretion function. Okay? So we do this by actually determining the amount, no, of bilirubin in the serum. So bilirubin is an end product of metabolism and the principal pigment in bile. And this is also formed from destruction of heme-containing proteins such as myoglobin, catalase, and cytochrome oxidase. So let's discuss briefly, no, bilirubin metabolism. So remember, your red blood cells are actually alive, no, or present in the circulation for 120 days. After 120 days, your red blood cells are actually destroyed, no, by the reticuloendothelial system, such that destruction now of your red blood cells, senescent or old red blood cells, no, or red blood cells that has lived its lifespan of 120 days, will actually produce hemoglobin. Okay? Your hemoglobin is actually broken down into its components, the heme and the globin component. The heme component contains actually the iron porphyrin, and the globin component is actually the protein, no? Protein component of the hemoglobin. So it's actually the heme that is metabolized and converted eventually to bilirubin. Okay? So your heme, so this actually happens in the outside, no, outside the liver. So your heme, okay, is converted by the enzyme heme oxygenase into biliverdin. Okay? Heme is converted by heme oxygenase into biliverdin. Your biliverdin is converted by biliverdin reductase into unconjugated bilirubin, also known as indirect bilirubin, or also known as B1. Okay? Now your unconjugated bilirubin, okay, attaches to a transport protein, albumin. Now once it is attached to albumin, your unconjugated bilirubin now is transported into the liver. Okay? It is transported into the liver via the action of the enzyme UDPGT. You got that? UDPGT, also known as uridine diphosphate glucuronyl transferase. Okay? Now, once your unconjugated bilirubin is in the liver now, okay, it is converted eventually, is conjugated eventually with glucuronic acid by the enzyme glucuronosyl transferase to form now your conjugated bilirubin, also known as direct bilirubin, also known as your B2. Okay? Now, a distinct characteristic of this conjugated bilirubin is that it is water soluble. And so, your conjugated bilirubin, okay, also known as direct bilirubin or B2, also known as bilirubin diglucuronide, is actually transported into the biliary system, no, included in the bile. Now, some of these components, no, of the direct bilirubin are actually transported into the small intestine, and by the bacteria, no, resident flora or bacteria in the small intestine is converted into urobilinogen and excreted out in the stool as stercobilin. Okay? Now, some of these urobilinogen is transported back into the liver via enterohepatic circulation, no, in the portal vein. And eventually, some of this urobilinogen is excreted out also in the kidney in the form of urobilin. Okay? So take note of that. Now, what I want to point out here are the following important points. Okay? So, in conditions wherein there is increased destruction of your red blood cells in the circulation, what's likely to happen? Increased destruction of your red blood cells or extravascular or intravascular hemolysis. What's likely to happen is that there is actually increased accumulation of your unconjugated bilirubin. Okay? Because your unconjugated bilirubin is actually formed from conversion of your heme component by heme oxygenase into biliverdin and biliverdin by the action of biliverdin reductase into bilirubin 2, B2 or unconjugated bilirubin, producing increase now in direct, okay, bilirubin. Now, in disease states wherein there is damage, okay, damage to your hepatocytes or injury into your hepatocytes, what's likely to happen is that the liver now will not be capable of conjugating bilirubin, okay, such that there would be now a defect in the production of your conjugated or direct bilirubin. Now, in disease states wherein there is obstruction, okay, obstruction in the biliary system, wherein your direct, there is actually normal conjugation of your protein or your bilirubin, thus eventually producing normal amount of direct bilirubin. What's likely to happen is that since there is obstruction in obstructive states, your direct bilirubin would not be able to pass through the biliary system. And so it would actually accumulate and eventually go back into the circulation. No? So when it accumulates in the circulation, when there is increased levels of your bilirubin in the circulation, it may be either unconjugated or conjugated. What's likely to happen is that it would actually produce yellowish discoloration in the skin and the mucous membranes. So I hope you got that. Now, to differentiate the two, okay, the two major types of your bilirubin, we have bilirubin 1 This is also known as unconjugated bilirubin or B1, okay? Or indirect bilirubin. This is water insoluble. That's why in the circulation, it has to be bound to albumin for it to be transported into the liver for conjugation. It is non-polar bilirubin because it does not dissolve in water. Indirect reacting bilirubin. Why indirect reacting? Because when you determine its level in the circulation or in the serum sample, what's likely to happen is that your bilirubin 1, since it is readily bound to albumin, since it is bound to albumin, it would not actually react with the reagents that you add to the serum. That's why it's called indirect reacting, because you have to remove first the albumin before your bilirubin 1 or your unconjugated bilirubin will have to react with the reagent. This is also known as hemobilirubin, slow reacting, and prehepatic. Okay? Why prehepatic? Because here, this is usually produced in the extravascular or intravascular circulation. No? Whereas your direct is produced in the hepatocytes. Your bilirubin 2 is also known as conjugated bilirubin. Okay? Is conjugated with glucuronic acid in the liver, as I have mentioned a while ago. Now, it is water soluble, thus it is considered polar. It is direct reacting. Since your bilirubin 2 is not bound to any proteins, what's likely to happen is that it readily reacts. It directly reacts with the reagents used to determine the amounts of bilirubin. This is also known as cholebilirubin and it is fast reacting. This is termed also as post-hepatic, no? Obstructive and regurgitative bilirubin. Why? Because going back in this diagram here, when it is known as post-hepatic, no? Obstructive or regurgitative, but basically because, again, I've mentioned when there is obstruction in the biliary system such that your direct bilirubin now could not actually pass through, it is actually regurgitated back, no, such that increased amounts would likely produce excess, no, in the extra or intravascular circulation, thus producing increased levels in the serum or circulation. Okay, that's why it's also termed as post-hepatic. Now, another bilirubin fraction is your delta bilirubin. This is a conjugated bilirubin tightly bound to an albumin. So it has a longer half-life because it is bound to albumin, and this is formed due to prolonged elevation of conjugated bilirubin in biliary obstruction. So this reacts with diazo reagent in direct bilirubin assay, and this is usually computed by subtracting direct bilirubin levels from total bilirubin and you add indirect bilirubin. So normally it is less than 0.2 milligrams per DL in the serum. Now these are your reference values, no, for your bilirubin. So other tests used to determine the liver function is by determining your ammonia levels and determining these enzymes, no, ALT and AST. So these are actually the ammonia, ALT, AST, also ALP, GGT, okay, LDH, and other enzymes is actually may be used, no, for determining the detoxification function of the liver. Let's start first with ammonia. So remember, your ammonia arises from deamination of amino acids, which occurs mainly through the action of digestive and bacterial enzymes on proteins in the intestinal tract. So this is released also from metabolic reactions that occur in skeletal muscles during exercise. So In other words, sorry, that's a typographical error. No, that should be ammonia. Ammonia. So your ammonia, in other words, is actually a metabolic waste products. Okay? So your liver normally removes most of these non-nitrogenous protein compounds via the portal vein circulation and converts it into urea, then eliminated by the kidneys. So your ammonia being a waste product in metabolism, metabolic waste products, is converted into urea, and then urea in the liver, and then urea in turn is excreted out in the urine, no, by the kidney. So elevated levels are actually neurotoxic and are often associated with encephalopathy. So if you have increased levels of ammonia, no, these are actually this is neurotoxic, and so it may be associated with encephalopathy. An important mechanism by which ammonia can cause toxicity to the CNS is its ability to lower the concentration of gamma aminobutyric acid, which is actually an important neurotransmitter. Now, another test, okay, used to determine the detoxification function of the liver is via determination of the different enzymes. So aside from ALT would mean alanine aminotransferase, AST or aspartate aminotransferase. Aside from that, we also have 5-nucleotidase. We also have GGT or gamma glutamyl transferase. We also have LDH or lactate dehydrogenase. Okay? So any injury to the liver results in cytolysis or lysis of the cytoplasm of the cell membrane of the hepatocytes and necrosis, thus causing liberation of the various enzymes. Because these enzymes are actually normally suspended in the cytoplasm of your hepatocytes. And so any injury that would cause lysis or destruction of the membrane of the hepatocytes would actually cause release of the enzymes. Okay? And this is used to assess the extent of liver damage and to differentiate hepatocellular function from obstructive mechanical disease. So enzyme tests are often the only indication of cell injury in early or localized liver disease. Of these enzymes, the most specific, most liver specific is actually your ALT. Okay? So a common manifestation of the accumulation of your bilirubin products is jaundice, no? Also termed as icterus. This must be ICTERUS, icterus or hyperbilirubinemia. So this is characterized by yellow discoloration of the skin, the sclerae and mucous membranes, and this is clinically evident when the bilirubin level exceeds 2 or 3 milligrams per dl. So the classification of your jaundice may be prehepatic or post-hepatic jaundice. Again, when you say prehepatic jaundice, there is actually increased accumulation of the defect is actually in the extra and intravascular circulation, wherein this happens only when there is increased destruction of your red blood cells, as seen in hemolytic anemias. No, post-hepatic jaundice is actually associated with obstructive type of jaundice. Okay, when there is obstruction in the biliary system, I've mentioned this already. And hepatic jaundice is usually seen in conditions where there is increased injury or destruction of the liver hepatocytes themselves. Okay. So this is an algorithm on how we approach patients presenting with jaundice. Okay. So we usually do ask the patients the history, no? And then we do physical examination. So as medtechs, this is where we come in, no? The determining the different laboratory parameters. So I've mentioned this already, no? The common parameters that we use to determine liver functions are the following. So we request for bilirubin determination, okay, which serves to um, assess what function of the liver, conjugation and excretion function. And then we have your ALT, AST, and ALP, or alkaline phosphatase, which serves to assess what function? Okay, detoxification function. Okay, and then could be also synthetic function, no? For your prothrombin time and albumin determination. So if there is only of these lab tests, only bilirubin is increased or elevated, if we determine now which particular bilirubin is elevated, if it is direct bilirubin that is elevated or direct hyper, we term it as direct hyperbilirubinemia, or what's the other name for direct bilirubin? B2 or conjugated bilirubin. These are the disease associated. So we have inherited disorders such as Joubin-Johnson syndrome and Rotor syndrome. And when there is only indirect bilirubin that is elevated, we usually see this in the following conditions. So when there is drug intake, no, of rifampicin, usually in the treatment of tuberculosis, no, rifampicin, and also in when there is overdosage of your probenicin. Now, it may be seen also indirect hyperbilirubinemia is usually seen in inherited disorders such as Gilbert syndrome and Crigler-Najjar syndromes. And also, as I've mentioned, in hemolytic disorders, no? Or when there is ineffective erythropoiesis. Hemolytic disorders such as autoimmune hemolytic anemia, okay? Sickle cell anemia, like that. Now, when bilirubin is elevated together with other liver function tests, together with AST, ALT, other liver function tests which are also abnormal, no, with bilirubin, what's likely to happen is that here is the algorithm. A hepatocellular pattern would actually mean that the defect is in the liver itself. If there is also elevated ALT, AST, and ALP. Okay? Higher ALT and AST than ALP. Now, this is usually seen, okay, in conditions associated with viral infection. So that's why we determine viral serology. So I will not be discussing this in detail because you will have a separate discussion in this in immunoserology. So we determine hepatitis panel, no? Hepatitis A, B, C, etc. And another cause of ALT, AST elevation compared to ALP is that in toxicology screen, no, or um, acetaminophen toxicity, okay? Or we also determine ceruloplasmin levels. And another is in we also determine anti-nuclear antibodies, okay? Usually in ANA, SMA, and SPEP, usually in systemic lupus erythematosus. Okay. Now, additional virologic testing would be determination of your hepatitis B and hepatitis E. And eventually, if this gives us normal or negative result, the last result would be an invasive, okay, invasive evaluation via liver biopsy. This is the last, no? Now, if alkaline phosphatase is more elevated, no, higher alkaline phosphatase compared to your ALT and AST, this is considered cholestatic pattern. So, what's likely to happen in cholestatic pattern, these are actually post-hepatic defects or disorders. For example, in obstruction in the biliary system. That's why we do ultrasound to determine if there is dilated ducts or extrahepatic cholestasis, which is usually seen in obstruction in the biliary system. Okay. Now, this is another algorithm, okay, that we use in the clinical setup when there is suspected liver disease. Okay. So, for example, you already notice that the patient has jaundice, okay, or has increased liver span or hepatomegaly. So what's likely to happen is that we classify it if it is acute or chronic. Usually acute if the disease condition of the patient has been less than 6 months, or chronic if it is more than 6 months. So usually, okay, for acute conditions less than 6 months, usually if there is hepatic, okay, hepatic pattern, I've mentioned already that there is more or less increased or higher levels of your ALT and AST compared to your ALP. When there is cholestatic pattern, there is higher ALP and GGT, or ALP is alkaline phosphatase, GGT is gamma glutamyl transferase. Higher levels of these two compared to your ALT levels. And so, we further work up patients with hepatic pattern with the following lab test. Okay, so I have mentioned this already, no, the ceruloplasmin, DNA, and hepatitis panel. And eventually, if there is normal or negative results, the last result would be invasive test or biopsy. And in cholestatic pattern, with increased ALP and GGT, these are the tests, okay, that we usually do. Now, for chronic states, in hepatic pattern, these are the tests that we do. The hepatitis panel, okay, ferritin determination, ceruloplasmin, ultrasound, and alcohol history intake. Okay, in cholestatic pattern, more or less the same, no? The same with acute. And our last resort would be determination of the abnormality via liver biopsy. Okay, so thank you very much for your kind attention. That would be all.